Good afternoon, everyone. Thank you for joining us on this last day of HOPA for lunchtime learning. My name is Sarah Hayward. I am the gynecologic oncology pharmacist at Stevenson Cancer Center in Oklahoma City, part of the University of Oklahoma. We will be learning about endometrial and ovarian cancer today, and let's go ahead and get started. Oh, backing up. Sorry, guys, a few housekeeping things. So joining me today is Dr. Jennifer McDonald and Dr. Aaron Zaholski. I'll introduce them a little bit more when it comes to their sections. We do want to thank PeerView for putting on this educational session today and our sponsors from AstraZeneca, GSK, and Merck. If you have not already, please do the pre-event survey. There will be additional polling throughout this session, so keep your eyes peeled for that and those QR codes. You will be able to submit questions. We will have a Q&A at the very end of this presentation. For our in-room learners, you can use your personal device to scan the QR code, and for those of you joining us virtually, you can respond to the polls on your screen. Also, if you would like to participate, QR codes also at each of your card, at each of your stations there, that you can scan to potentially win a $50 gift card. So if you'd like to participate, please do so. And also, we're going to go through some slides pretty fast today. We have a lot of content we would like to cover, so please know that after this session, all of these slides are available to you. You may download them and you may have access to them, as you can see here at the website. So here are our goals for today. We are going to talk about evidence that supports the use of biomarker-driven treatments in our patients with endometrial and ovarian cancer. How do pharmacists play a key role in personalizing treatments for these patients, and then applying team-based strategies. As we know, pharmacists are all part of a team to make sure that we do our best to optimize treatment compliance and hopefully outcomes with our patients. All right. Just to get us started, a few statistics about endometrial and ovarian cancer. As you can see here, uterine cancer represents about 3.4% of all new cases, and ovarian cancer about 1%. As far as age at diagnosis, this tends to come on in the mid-60s for those born biologically female. And as I also want to point out, as I'm sure we're familiar with, the relative 5-year survival. With endometrial cancer, obviously much higher because these patients tend to present with signs and symptoms, specifically postmenopausal bleeding. And my public service announcement to all of you females and all of you who know a female, which is all of you in the room, any postmenopausal bleeding is not normal. Never is. Get it checked out. When we go to our ovarian cancer, we see a much lower 5-year survival. That's just because this is a silent disease. It tends to grow without having much symptoms or symptoms that can be confused with other diseases. And so it's an unfortunate part of the disease. Looking at mortality rates, overall, all cancers, we are seeing a decrease in mortality. One thing to point out that's a little bit different with the gynecologic malignancies is we are seeing an uptick in not only cases of endometrial cancer, but also mortality with endometrial cancer. Some of this is thought to be related to the United States obesity epidemic and increased morbidity associated with those patients, which can obviously affect outcomes. Looking at survival, it's always important across all of our cancer types to talk about disparities in healthcare. For many different reasons. We can also see this can be race-associated disparities. If we look on the left-hand side for ovarian cancer, again, a decrease in mortality over the last over this 30-year time frame versus endometrial, where again, we're starting to see an uptick. This is all races. When we separate out those Black patients, unfortunately, we do see quite an increase in mortality with endometrial cancer, specifically due to certain histologies and problems with care. Quick slide, we all know pharmacists are a key player in the oncology care team. We work with our oncologists, we work with our APPs, we work with the nurses to make sure we can ensure patients have access, patients are educated, and we're able to monitor and treat those adverse events accordingly. Once we get to the end of the 3 presentations today, we will be going over some patient cases. One will be for endometrial cancer, one will be for ovarian cancer. So as we go through this presentation, think about when we're thinking about our patients, is biomarker testing needed? What are the outcomes of that? How does it direct and guide our treatments? And also always making sure we keep in mind a patient-centered and focused approach. We can tell a patient what we would like to treat them with all we want, but we have to have their input on how it's going to affect their life and lifestyle moving forward. Okay, so we are going to break this into 3 sections right now. We're going to discuss PARP inhibitors, then we're going to discuss immune checkpoint inhibitors, and then antibody drug conjugates. So, again, my name is Sarah Hayward, and we're going to talk about PARP inhibitors pretty quickly. Quick slide for your reference about the mechanism of action of PARP inhibition. Again, so just as a refresher, the idea is that we are preventing these cells from repairing their DNA abnormalities. So we have, instead of single-stranded repair breaks, we have double-stranded breaks, which lead to ultimately to cell death. And we do know in those patients who have a deficiency in their homologous recombination pathway, we tend to see better outcomes with our PARP inhibitors. This slide also, as a quick review, as we talk about biomarker-directed therapy, is just to point out that approximately 50% of our patients with high-grade serous endometrial cancer, which is the majority of our ovarian cancer patients, do have some sort of homologous recombination deficiency, which means they lack an ability to repair DNA in cell replication. Of those, so under the big umbrella, that is HRD for short, we have our BRCA population. So we need to keep in mind that even though it's not the largest percent of population with ovarian cancer, it's still substantial and they still have guided and directed therapies. All right, talking about PARP inhibitors, here is their clinical space right now as of today, March 2026, I'm not really sure, but March 2026, is they are approved for use in the maintenance setting. You have a patient with epithelial ovarian cancer. They have received their frontline treatment with platinum-based therapy. They have had a complete or partial response to therapy. If they have a BRCA mutation, regardless of germline or somatic, you may use a PARP inhibitor of choice. Those that are approved in the ovarian cancer space, olaparib, rucaparib, or niraparib. Also, for our patients who might not have a BRCA mutation, but they do have some sort of HRD positivity, and we used bevacizumab with upfront chemotherapy, again, a platinum-based combination. We also have the option of carrying on with those PARP inhibitors, or we can add olaparib or niraparib with our bevacizumab. In the setting of no BRCA mutation, in the setting of homologous recombination proficiency, we currently don't have any recommendations for maintenance therapy. We also have the option for maintenance therapy in the recurrent setting, as you can see here, but it even gets further, it's further limited to just those patients with a BRCA mutation, and ideally if they have not already had exposure to PARP, there's some exceptions to that, but we're not going to get into that today. This is a quick slide I just wanted to review about why it's important to continue to evaluate your data over time. If we go all the way back to 2014, we have our first approval for PARP inhibitors, olaparib, for treatment and recurrence of ovarian cancer, specifically those BRCA mutant patients. Then we get approval in the maintenance setting. Then we get approval in the maintenance setting for all comers, so regardless of any sort of molecular testing. And then we had a period of time where we were using PARPs for maintenance, we were using them for treatment, and then more data started to evolve. We get to 2022 where we started to we had the complete removal of all PARP inhibitors for treatment. Based on some of our clinical trials, we actually saw a detriment in some of those patients and they had worse outcomes with their PARP inhibitor. And so 2 of those agents were removed from market and the other one saw the writing on the wall and followed suit. We also recently had the removal of all-comer data, so patients who are BRCA negative, who are HRD negative, we don't have a space for them. And we'll look at the data here in a minute from the PRIMA trial that got us that. So right now, maintenance only, frontline or recurrence, must be BRCA mutant, must have or HRD positivity. All right, quickly, Solo-1, we're all familiar with this landmark trial that got us the approval of olaparib for those patients in maintenance setting who were BRCA mutant. Our 5-year survival data, 70% decrease in recurrence of their ovarian cancer. This is amazing and wonderful. So the take-home point with this slide is if you have a patient with ovarian cancer who's completed their therapy and they are a BRCA mutant patient, you should absolutely do your best to get them on PARP therapy. That's the story. PAOLA-1, this is the data for olaparib plus bevacizumab. Remember, we're only using this if bevacizumab was used in the upfront setting. As we can see, so this again showed great benefit to those patients who had a BRCA mutation or were HRD positive. We do not have this approved in the HRD negative setting. PRIMA. So this is the study for niraparib in frontline maintenance therapy. And as we can see, let's see if I can use my little pointer here. At our 6-year data follow-up in the overall population, we found negative or no benefit to the patients getting niraparib versus placebo. And so we still do have good data for this in the HRD population, which includes our BRCA mutant patients. What about combinations of PARPs and immune checkpoint inhibitors in ovarian cancer? Ovarian cancer, time and time again, has shown not to really be the greatest in responding to immune checkpoint inhibitors. Here's the data for you. Just to show we really didn't see big increases in overall survival or progression-free survival with the addition of immune checkpoint inhibitors in this space. What about endometrial cancer? Well, yes, actually we do. We do have some data from RUBY Part 2, which look at the combination of niraparib and dostarlimab in the maintenance setting for endometrial cancer. So this was after they received their frontline chemotherapy with or without immune checkpoint inhibitors, and then with the addition of a PARP inhibitor. So we have RUBY and we have DUO-E. So these did show some meaningful benefit in progression-free survival for the addition of these PARP inhibitors in the pMMR population, because we already know patients in endometrial cancer space who are mismatch repair deficient versus mismatch repair proficient. Mismatch repair deficient, we absolutely know immune checkpoint inhibitors in certain stages of disease is very important, but do we get any benefit with the addition of PARP? In certain situations, we could. Very quick side, just going over AEs of PARP inhibition. To save time, I'm just going to let you guys look at this very quickly, and we're going to move on. Also, as pharmacists, we want to make sure that we're involved in the patient education process, making sure patients are aware what to expect, when to expect it, and not only those side effects, but monitoring. How often do I have to come back to the clinic? How often am I going to have labs done? So making sure we keep that in mind for our patients. So, takeaway for PARP inhibitors. We want to ensure proper place in therapy for those patients with ovarian cancer. And as we see, data changes over time. So it's important to keep up with that. We want to work alongside our specialty pharmacy team for access to these medications, which can be very financially toxic or sometimes even hard to get a hold of, depending on insurance approvals. Making sure that we set expectations of therapy and we work with our patients to maintain compliance, because if they're not compliant, it doesn't do anyone any good. Following up regularly and making sure not only we know, but our team knows, the people that are taking those triage calls, the people that are also seeing those patients at the clinic, they know what to ask and what to evaluate for and what might need addressing. So, poll for you real quick. Again, these are located on your desks as well on those little cards. We're going to move on. I'm going to hand over this to Dr. Erin Zaholski. She's a clinical pharmacy specialist, also in gynecologic malignancies at VCU, and is also the professor of the Department of Pharmacotherapy. Erin, here you go.
Thank you so much, Sarah. I'm excited to talk about immune checkpoint inhibitors, mostly in endometrial cancer, but also a little bit in ovarian cancer too. We'll start off with the PROMIS classification system. Is anyone familiar with this molecular classification system in endometrial cancer? Super. Okay, so whereas historically endometrial cancer was grouped by histopathology, type 1 and type 2, as we understand molecular biology about endometrial cancer more, we have distinct molecular subgroups that patients are subtyped into. These include the bolded colored boxes on the slides. This comes from the large TCGA study and then was further refined by a study called PROMISE, which gives us this algorithm for testing to be able to easily subclassify patients. So these include POLE hypermutated, it's a DNA proofreading gene, deficient mismatch repair, a microsatellite instability high group, and then no specific molecular profile or NSMP, and then P53 aberrant. These are prognostic categories, and more we're finding out that they can be predictive of treatment response as well. Honing in a little bit more on MSI high, if you look at this study that did tumor exome sequencing in 18 cancer types, you can see that uterine cancer has the highest rate of MSI high cancers. And actually 25 to 30% of endometrial cancers are dMMR or MSI high, which leaves the majority still as proficient mismatch repair or microsatellite stable. So given the high rate of dMMR in this population, it's no surprise that immune checkpoint inhibition has been heavily studied. This, of course, starts with a backbone of first-line carboplatin and paclitaxel in the advanced or recurrent endometrial cancer population, and that was the standard of care for decades. And then as time went on, immune checkpoint inhibitors became integrated into the second and subsequent line treatment of patients with endometrial cancer in the recurrent and metastatic setting based on results of the Keynote 158 trial and Garnet trial for immune checkpoint inhibitor monotherapy, and then combination therapy with Len-Pem or lenvatinib and pembrolizumab for patients with pMMR endometrial cancer in the second and subsequent line setting. What I'll really focus on today are the last boxes on this slide, and this is immunotherapy combined with platinum-based chemotherapy for the first-line treatment of patients with recurrent and metastatic endometrial cancer, which has really been the hot topic in the past few years. Here you can see the FDA-approved indications for frontline immunotherapy and chemotherapy and the trials that we'll give a brief overview of. What I want you to pay attention to is that there are differences in the indications between immune checkpoint inhibitors, specifically in relation to which population they're indicated for. So you can see that dostarlimab and pembrolizumab both have indications in dMMR and pMMR patients in this setting, whereas durvalumab has an indication for dMMR endometrial cancer only. I'll give a high-level overview of the studies that led to these approvals, trying to pull out some unique characteristics that can help in treatment planning. These are all studies evaluating patients with advanced or recurrent endometrial cancer who have not been treated with chemotherapy in this line of therapy, but they could have had adjuvant chemotherapy, in this case, in the RUBY trial, greater than or equal to 6 months ago. An important point here is that carcinosarcoma and aggressive histology was allowed, and the RUBY trial also included patients regardless of having measurable disease if they had high-risk stage 3 or 4A endometrial cancer. So a little bit different of a population than we'll see in future studies. They were stratified by these features, and patients were randomized to dostarlimab plus carbotaxol for 6 cycles, followed by dostarlimab every 6 weeks for up to 3 years, or carboplatin paclitaxel plus placebo and placebo maintenance. They had co-primary endpoints in this study of progression-free survival and overall survival, so went for OS right off the bat. And here you can see their results and their survival curves in their dMMR population. These hazard ratios are pretty profound in favor of dostarlimab, 0.28 for PFS and 0.32 for OS. So this led to the FDA approval of dostarlimab plus chemotherapy in 2023 for the dMMR population. However, they also found a PFS benefit in the pMMR population as well. You can see the hazard ratio presented on the left here. The hazard ratio was 0.76, and this was statistically significant, but you can also see that's nowhere near as profound as it was in the dMMR population as expected. However, the FDA approval was expanded for dostarlimab plus chemotherapy in this setting to the pMMR population. Moving on to the NRG-GY018 trial, we had a similar population here. Adjuvant chemotherapy had to be greater than or equal to a year in the past. This study did not include the carcinosarcoma histology, and all patients had measurable disease. Patients were randomized to Pembro plus carbotaxol or placebo plus carbotaxol, followed by Pembro maintenance or placebo maintenance for up to 14 cycles, and this shakes out to be about 2 years, so that's a difference between dostarlimab. Their primary endpoints were different too. Their primary endpoints were PFS in the dMMR population and the pMMR population, so statistically powered to detect differences in those subpopulations. And this is what they saw. Our results in the dMMR population mirror that we saw in RUBY, hazard ratio of 0.3 in the dMMR cohort. In pMMR, they found a hazard ratio of 0.54 in favor of pembrolizumab, and the median progression-free survival difference was about 4 months. So this led to the FDA approval of Pembro plus chemotherapy in this setting for both the dMMR and pMMR population. Finally, we have DUO-E. In this study, it was a lot different because patients could be randomized to one of 3 arms. So here you see arm A was their control arm, and that was platinum chemotherapy and placebos for durvalumab and olaparib in the maintenance setting. Arm B was platinum chemotherapy with durvalumab, followed by durvalumab maintenance plus placebo olaparib. And then arm C was platinum chemo durvalumab, followed by olaparib and durvalumab maintenance. Their primary endpoint was progression-free survival for arm B compared to arm A and arm C compared to arm A. So they were comparing back to that carbotaxol backbone alone. Here you see their results in the dMMR subpopulation, and this mirrors what we see in our previous 2 studies that we talked about. The question of adding the PARP inhibitor, how does this improve therapy further? Well, numerically it does, but remember the primary endpoint was comparing to control, not comparing durvalumab versus durvalumab and olaparib. This data led to the approval, the 2024 approval of durvalumab plus chemo in patients with dMMR. Note that we don't have an approval for olaparib in this setting. There are certainly a lot of logistic, efficacy, and toxicity considerations to communicate with patients, and I think this is really important. This is a patient population used to that finite chemotherapy of carbotaxol, and now we're adding something that they could potentially continue until disease progression or unacceptable toxicity. For adding immunotherapy logistically, note that the duration of therapy differs between these agents, Pembro being up to 2 years, dostarlimab being up to 3 years, and then durvalumab until progressive disease or unacceptable toxicity. So I think this is really important to communicate up front. I think it's always great to discuss the goal of therapy and efficacy and reiterate the conversation that these patients are having with their oncologist. And I think this gives us an opportunity to personalize expectations based on features of the patient. So those results looked a lot different between dMMR and pMMR. And then, of course, toxicity. We're not just counseling on our carboplatin paclitaxel adverse effects anymore. We're definitely talking about things like peripheral neuropathy and myelosuppression, but now we get to bring in the immune-related adverse effect counseling. And so I'll talk a little bit more about how I approach this later, but I think grounding the patient in some statistics of, kind of how often these happen can be really helpful, and of course, what and when to report. If you haven't heard the LEGS mnemonic for immune-related adverse events, you should, and now you've had. This is really helpful for your learners, also can be helpful with the savvy patient, and it represents the most common IRAEs that we see, and we see this replicated across endometrial cancer. No real differences there. This is a slide for your reference on management of common toxicities, but please refer to the NCCN guidelines as well. And then timing is also really important when you're giving a combination chemotherapy, immunotherapy regimen, because there can be some overlap. As you all may know, a subcutaneous formulation of pembrolizumab is now FDA approved for all indications. This applies to endometrial cancer as well, and we're excited to touch on that in the case discussion. Second-line immune checkpoint inhibitor regimens still exist, and there may be patients who haven't received immune checkpoint inhibitor up front since this is newer data. So we still need to be paying attention to our Keynote 775 data, combining lenvatinib and pembrolizumab, as well as our monotherapy indications. And I think there are a lot of pro tips about managing patients on lenvatinib and pembrolizumab, including carefully considering a starting dose. The FDA package insert recommended dose is 20 milligrams per day of lenvatinib, but we have some retrospective data that may support some empirically lower doses for certain patients. Also, keeping an eye on toxicity overlap can be really helpful, noting that lenvatinib is going to have a much shorter half-life than pembrolizumab. So for a mild or moderate toxicity, holding that lenvatinib may clarify which agent is causing the toxicity. And then to wrap it up quickly, we'll talk about immune checkpoint inhibitors in ovarian cancer. As Sarah mentioned, it really hasn't been transformative in ovarian cancer the way that endometrial cancer saw it be. But last month, we had a checkpoint inhibitor FDA approval in platinum-resistant ovarian cancer that, based on the results of the Keynote B96 trial, which combined pembrolizumab with paclitaxel plus or minus bevacizumab in that platinum-resistant ovarian cancer population. And here you can see the results of the Keynote B96 trial. They found about a 2-month progression-free survival benefit with the addition of pembro and about a 4-month benefit in overall survival with the addition of pembro. So in conclusion, some important considerations when integrating checkpoint inhibitors is to carefully consider the trial inclusion criteria and the type of population, what approvals are out there, and the patient in front of you and their molecular classification. And then education is absolutely key when you're counseling on these complex multi-drug regimens, and we can be critical in having the patient report immune-related side effects and then also managing them according to evidence-based practice. So please take a moment to answer a follow-up poll, and I will hand it over to Jen McDonald.
All right, so I'm grateful, to be talking about what I'm going to argue is the most exciting topic going on in gynecologic malignancies. You know, we've refined PARP inhibitors in ovarian cancer. We're still completely determining the role for immunotherapy and PARP inhibitor, particularly in endometrial cancer. But we're going to talk about antibody-drug conjugates in the gynecologic space. There's a lot to talk about with patients and with providers when we're discussing ADCs in this space. I think whether or not you need tumor testing or that for approvals and for considerations of therapy, as well as clinical trials. So this is a huge clinical trial space. I'm going to try and focus on this throughout the presentation. And we as pharmacists play a vital role in helping to recommend and make sure that we're aware of what clinical trials are available to our patients. The other thing that I'll put a plug in for here in ovarian and endometrial cancer is to make sure that you are doing tumor testing very early on to evaluate what therapies are going to be best for your patient, whether that would be a PARP or IO. When we talk about antibody-drug conjugates, I always think ADC 1, 2, 3. So there are 3 components to your ADC. You have your target, your payload, and then your linker. And all 3 of those components are vitally important to the appropriate delivery, the safety, and the efficacy of these therapies. So when you're looking at your target, you want it to be tumor specific. I'm not telling you anything that you don't know. You want to deliver a cytotoxic payload specifically to those tumor cells, but that linker too is extremely important for diffusibility across the tumor cells to make sure that it stays together and delivers appropriately just to the target of interest. And then we also talk about DAR, so drug to antibody ratio, which is basically the amount of drug that you're going to deliver to that target. So you'll see 8 to 1 and things like that. All of that do become important. We have seen in this space in particular, drugs fail because the DAR was inappropriate. So you saw too much toxicity and not enough efficacy. So when we look at current approvals for ADCs in the ovarian and endometrial cancer space, we have mirvetuximab, which is our folate receptor alpha, that has approval for high expression levels in the second line or higher setting, primarily in platinum-resistant ovarian cancer. We do have some data to use it at lower expression levels in combination with bevacizumab and is in the guidelines. And then we have TDXD or trastuzumab deruxtecan, which is a HER2 target, delivers topoisomerase 1, and it has tumor agnostic approval for 3+, but is in the guidelines for 2+ or higher, and we're going to look at that data from Destiny Pan-Tumor. And then we have several other ADCs in development that target folate receptor alpha and HER2 expression that we'll look at. So Rina-S, Tervuta-S, Sofabart, which we're not going to talk about today, but tizitamab, and then DB1303 with BNT323. So a lot going on in this space. And then additionally, we have even more ADCs that are being looked at and likely to see potential approvals in the coming years. So we have TROP2 targets with sacituzumab, dapatamab, we have the B7H4, puxitotug and morsetotug. I'm sorry if I mispronounce anything to anyone in the room. You can correct me later. I've practiced 20 billion times and I'm still going to get it wrong. And then we have B7H3 with the DB1311, and then ifinatamab, CDH6, which is very exciting, likely to see an approval soon for that. So raludotatug, and then HER3 with patritumab. So again, if I can emphasize anything, there is a lot coming and you are to see more. My joke is we don't just give carbotaxol in gyn cancers anymore. So when we're looking at the approval for mirvetuximab, this is a brief review. I'm not going to spend a lot of time here, but folate receptor alpha is highly overexpressed in ovarian cancer. Up to 85% of cells overexpress folate receptor alpha, so it's a great target. You're going to see this probably a folate receptor alpha expand in other tumor spaces as well. In the payload here is a microtubule inhibitor. So kind of similar microtubule potential effects, but the additional of ocular toxicity that we talk about with mirvetuximab. In the MIRASOL, which is the phase 3 study, so keep in mind that they needed to have a folate receptor alpha expression of over 75% to be in this trial. We did see a statistically significant improvement in progression-free survival as well as overall survival. So we love to, in ovarian cancer, my joke to my residents is we love a 1 to 2 month PFS and about a 4-month OS, and we will get an approval. And that is what you see with the MIRASOL data. When we're looking at future folate receptor alpha targets, so we have Tervuta-S, and then we're also going to review Rina-S as well. These are great because they don't actually require folate receptor alpha testing. So in the Tervuta-S, the expansion phase, so we're going to focus on that part B, does require more than 25% tumor expression, and I love a good waterfall plot, right? We all love a good waterfall plot. And we can see, and it's my gosh, an overall response rate of upwards of 54%, which for platinum-resistant ovarian cancer is particularly attractive. In Rina-S, so again, no folate receptor alpha expression level is required here. The payload is a topoisomerase 1 inhibitor. We can see a statistically significant improvement in objective response rates here. So we're seeing high rates of objective response rates in ovarian cancer and in endometrial cancer, which is very exciting for both of these spaces. So now we're going to move into HER2 targeted therapies, and I think we've all kind of drilled in Destiny pan-tumor, so I'm not going to spend a lot of time here, but I do like to highlight we are cool with Destiny pan-tumor because I think we saw some of the best results in the gynecologic malignancy space, and we're going to look across tumor types. So I know that the tumor agnostic approval is for 3+, but in NCCN we use it at 2+ or higher. And you'll see that proven here. So if you look at all comers, in the gynecologic space, you'll see a 61% objective response rate for 3+ and a 28% at 2+. If you focus on endometrial and ovarian, I know cervical isn't up here, but I'm going to give a nod to it. That's also important to be looking at. You can see even higher in endometrial cancer, so 85% at 3+, 47% at 2+, and then in ovarian cancer, 64% at 3+, and 37% at 2+, which put this into the guidelines, also got it tumor agnostic approval. T-DXd has a lot of trials ongoing, and we'll talk about this in the cases in particular, but there are more trials exploring it in the first-line setting for HER2 overexpressing ovarian cancer as a maintenance strategy with or without combined with Bev. And then you've got Destiny Endometrial 01, which is actually looking at it in the frontline setting, combining it with immunotherapy, and then comparing that to chemo plus immunotherapy. So just want to clarify those arms there. Arm A is T-DXd, rilvegostomig, and then Pembro plus T-DXd is Arm B, and then Arm C is chemo plus IO. And then Destiny Endometrial 02, you're comparing it in the adjuvant setting after radiotherapy. So a lot of going on in this space, particularly in endometrial cancer. If you have not heard of the 5 S's when you're looking for pneumonitis with ADCs, I'm happy to present this to you today. So the 5 S's: screen, scan, synergy, suspend treatment, and steroids. So we're not going to spend a lot of time at this point, just for time's sake, But recognizing early pneumonitis, knowing that most therapies it's not recommended in the package insert to continue if they're grade 2 or higher. So you want to catch it radiographically before the patient actually has the symptoms so that you can continue that treatment, particularly with the objective response rates and the improvements in PFS that we're seeing for patients. A newer therapy that we have, so cadherin 6 is a good target for ovarian cancer. Again, highly overexpressed in ovarian cancer cells. And we have this tetrapeptide-based linker for topoisomerase 1 payload. It's being looked at in both platinum-resistant ovarian cancer as well as platinum-sensitive ovarian cancer. And we're seeing very high objective response rates in early phase 1 trials. So a lot of excitement. This has rolled into its phase 3 trial. So the REJOICE phase 2 and 3 trial for ovarian cancer, I'm going to focus you in on that 5.6 mg per kg dosing because that's what has been moved forward with in the phase 3 trials, and it's currently being compared to a physician's choice standard of care with gem, Doxil, Topo, or Taxol. And we are seeing, again, very high results for both the platinum-sensitive and platinum-resistant settings, and more expansion, again, combining it with bevacizumab and kind of future uses here. So something that has been designated breakthrough status and we're likely to see approvals for very soon. In the way of TROP2, we do have DATO-DX and SAC-TMT that are also highly overexpressed with TROP2 in endometrial and ovarian cancers, and a lot coming in this space as well. So when we look at the TROPION study, which is a pan-tumor basket trial using DATO-DX at 6 mg per kg for both endometrial and ovarian cancer. As you look at the platinum sensitive for ovarian cancer as well as platinum resistant, we're seeing good objective response rates there at 42%, and then in endometrial cancer, not quite as strong, but still strong at 27.5%. So again, a lot going on in this space. When we look at SAC-TMT, again, we're seeing high objective response rates for both endometrial cancer as well as ovarian cancer in latter line stages. I'm going to say I think a lot to come for us is going to be sequencing this, right? How do we sequence ADC after ADC? Does the target matter? Does the payload matter? Could you target the same payload, but target the same target like HER2 but deliver a different payload and still see efficacy? Could you use a different target but a same payload and still see efficacy? A lot of trials are excluding those things, so it's going to be something that we in the real world are dealing with and kind of questioning and seeing what happens with sequencing with these therapies. When we're talking about ADCs, there's a lot to toxicity. Mucositis, I'm going to leave this slide here. I think it's a great slide for you. I think when I teach patients, the biggest thing here is prevention. It's really hard to fix mucositis and to manage mucositis once it's developed, so making sure that patients have appropriate oral care and prevention strategies in place. And then very quickly trying to optimize as much as you can in supportive care. So if it's severe enough, I have admitted these patients to the hospital for PCAs and kind of help to make sure it's managed appropriately. So when we're looking at ADCs, there's been a lot of activity here. Just remember ADCs 1, 2, 3. You've got 3 components from a pharmacology standpoint. All 3 of those components, I know we don't focus a lot on the linker, but that is very important for drug development. A lot of approvals already, expansion is coming. And then knowing when you need testing, when you don't need testing, that's going to be a huge part of our role. If anything that you can advocate for in this space is to get testing early for patients so that you can determine therapy designations on recurrence instead of trying to wait for that stuff to come back to figure out where to go next. And clinical trial enrollment. So enrolling these people in clinical trials and getting them on trials early. A lot of these ADCs, which I didn't touch on, are only enrolling at like 3rd line or sooner. So it needs to be 1st line recurrence or 2nd line recurrence that you're getting these people into clinical trials, and then recognizing toxicity and counseling early and managing it aggressively. And with that, I'm going to refer you back to the polling question, and we are going to move into our cases.
All right. Got some questions here. We're going to try and see if we can incorporate them into our case discussion. Thank you so much, Dr. Zaholti and Dr. McDonald. Great job. Great job. So first, let's talk about an ovarian cancer case. So we have a patient who was diagnosed with stage 4 high-grade serous epithelial ovarian cancer. You can see her comorbidities there. She just recently completed her combination therapy with Taxol and Carbo. You can see her genetic testing there, BRCA wild type, HRD positive. She does have some PD-L1 expression and her folate receptor alpha. The plan is to start her on niraparib, 200 milligrams once a day. So the question is, what is the role of the pharmacist in counseling and treatment planning? Jen.
Yes, so I think there's a lot here. I think what we've learned at our center is the earlier that you talk about PARP inhibitors with patients, the better it's going to go. So it's a discussion that we have in the very beginning, regardless of whether or not we have their germline or somatic testing back. So we're going ahead and saying, if this does come back positive, we'll be talking to you about a maintenance strategy that we're going to use for your tumor, and then setting expectations for what that will look like. I tend to have those conversations a couple of times, like just a reminder, and then once the germline and the somatic testing are back, finalizing that discussion. We're not going to move forward for this reason. You're not HRD or, HRM, I'm sorry, I'm like, it keeps changing.
Yes.
How we're supposed to say it. But you're not homologous recombinant mutated, you are homologous recombinant mutated, as well as talking to them about their BRCA mutation and what that means and why these therapies would be important for them in the improvement, but the toxicity and the monitoring that they're going to need to go through.
All right, thank you. And Erin, if you could address, how do we ensure adherence, or what's your approach to ensuring adherence to oral therapies?
Yeah, absolutely. So I think that frequent check-ins throughout the patient's therapy are really important, but I think what's more important is being proactive and making sure they're going to be successful in a PARP inhibitor therapy from the start. Many of the toxicities occur early on and then get better as time goes on. And we do have some data that survival isn't impacted by dose reductions from a solo 2 subgroup analysis. So I kind of use all this in my counseling to build the patient's confidence and say, this is a therapy that you are going to be on for 2, maybe 3 years. It's really important that you have a good day-to-day quality of life. And if that means we need to take short breaks or make dose reductions, then that's what we need to do. And we don't think that that has any impact on survival. And I think knowing that up front overcomes the high achiever perfectionist qualities of some of our lovely patients. And I think that really helps. And so in that first month of therapy, we see our patients every week and do labs every week. That way we can have a close touch to make these dose reductions and holds early on. And I think ultimately that improves adherence throughout their therapy.
All right. So with this patient, we did start her on niraparib, 200 milligrams once a day. 2 weeks after starting this regimen, her platelets dropped from 250 down to 90K. So the question is, what would be the next steps and how can we use weights and plates? So just to discuss that, as we were preparing for this talk, we had 3 different approaches to this answer. So I'll tell you what mine would be and summarize for Dr. Zaholski and Dr. McDonald. So with the PARP inhibitors at my institution, even though package insert for niraparib states that, package insert for niraparib states that we need to be monitoring labs weekly initially, and then we can move out to monthly. We do this for all of our PARPs across the board, really just because it makes it simple for the team to know PARP, okay, here's our lab plan. We do know that looking from clinical trials with niraparib, we did see some substantially more thrombocytopenia in the patient population across the board. So there's a couple different ways to approach this. Also in the package insert, you're going to find information called weights and plates. So based on what the patient weighs when initiating therapy and what their platelet level was could determine whether you're going to start with a 300 milligram once a day dose or a 200 milligram once a day dose. So with niraparib, we have 3 options, 300, 200, or 100. These are all once a day. In my particular institution, we would be holding therapy. We would be rechecking platelets every 3 to 4 days. We would, if she was on 200 and we felt strongly about carrying on with niraparib, we might consider dropping it to 100. At my institution, we would also not consider it wrong if we were worried about continued thrombocytopenia to even trying an alternate PARP inhibitor. And I think the other question is, and I'll just let Dr. McDonald address this a little bit
Yeah, I mean, we watch trend really closely. So sometimes, let's say at this 2-week mark, it had gone from 250 to 110. I'm going to hold, or I'm at least going to go ahead and start a dose reduction because I know the trend, right, is probably next week they could be, I don't know, 50, right? Or we've all seen patients, you probably have in the audience, that come in the teens, right, and they get really, really low. So I think monitoring this trend is really important. I'd say the other thing that I make sure for all of our patients, I think we all do, is they have someone to contact when they're feeling bad, because sometimes they start feeling bad and I want to know right away so that I can hold, get labs, and figure out what's going on for the patient. We've had success even when people drop down really low at restarting niraparib at 100 milligrams a day, so we don't get scared if they get really low. We give them that 28-day period to recover. If they do, then we restart at a lower dose.
All right, thank you. So next section for this ovarian cancer patient, what if she had a BRCA2 mutation? Any additional discussion points if she were on an olaparib plus or minus a bevacizumab regimen? So obviously, as far as we know, there's different dosing between olaparib plus niraparib, BID versus once daily, and a few subtleties and difference in side effect profile. But I think the big difference for the patient is going to be carrying on with IV therapy, right? So bevacizumab, we're still going to be giving this once every 3 weeks and making sure they understand how this is going to affect their daily life and how long-term they're going to continue on their bevacizumab therapy. So making sure that they're aware that this is a twofold approach to treatment. And then what if patients have questions about how treatment impacts their daily routines, right? So we said early on, it's always important to take into consideration the patient's life. This is their life. They have free will. Some patients, I am from Oklahoma. We have a very large rural population, patients who are driving 2 or 3 hours for their treatment. So taking that into consideration. Also, when we think about toxicities associated with some of these medications, specifically bevacizumab, we know we can see hypertension either starting or increases in hypertension. Again, I am from Oklahoma. We are not the healthiest state, and so we have to keep some of these things in mind and monitor it closely. Okay.
And one quick thing to add there is, if you didn't give Bev with chemo, you're not going to start giving Bev in maintenance. So I think institutional practices differ, right, for if you use Bev in the frontline setting and how you use Bev in the frontline setting based on the GOG 218 data. So, how that's used at your, I know we get a lot of questions sometimes. So if there is a patient, when you're looking at approvals, right, who is BRCA mutated, olaparib, single agent, but if they're HRD, that data was from Payola in the combination with Bev and olaparib. So then, niraparib has been looked at for HRD. So, I mean, it does come down to looking at those charts, to looking at the data and really determining what makes sense for that patient. What did you use in the frontline setting? We know that Bev does not have a benefit if you didn't use it with chemo first.
Yep. All right. So to add another twist on this particular patient case, this patient, the plan is to start pembrolizumab every 6 weeks plus weekly paclitaxel. This is based on the Keynote B96 data that Dr. Saholsky presented. So if we're aware of counseling points, right, just for the LEGS acronym that we learned for patients who are on immune checkpoint inhibitors, but what about all the rare stuff, right? What about everything else that can potentially be cause a side effect, or a side effect that can be caused anywhere in the body? How do you approach that? The rare stuff.
Yeah, absolutely. I think we'll point out that we've all had deaths from immune-related adverse events in our clinic. You don't forget those, and I think immunotherapy is not a benign therapy. You can see rare toxicity, you can see serious toxicities. And so I think to help facilitate informed consent, we need to lay all that out realistically for patients. So where I usually start is kind of with the numbers. 1 in 3 patients will experience an immune-related adverse event. This is usually mild. However, about 1 in 20 will experience an event that's serious enough to put them in the hospital. So I think laying out these numbers can be helpful. And then I do use LEGS. I really love the ASCO diagram that has a picture of a patient's body and all the different potential places that inflammatory destruction can happen. I highlight LEGS to say these are the most common, and these are the exact symptoms that you need to look out for and call us right away if they occur. But then I also say that a lot of odd things can happen. This can happen to any organ system. So if anything unusual at all happens, no matter what it is, let us know and let us know early and giving them that contact. So that's really how I approach the general IRAU discussion.
Okay, and since we're starting this patient on this new regimen, this Keynote B96, which is going to be weekly Taxol plus or minus pembrolizumab, what do we need to know from the pharmacist standpoint that's different in this particular scenario? And I think if we, I don't know that we showed it necessarily, but if you look at how this particular study was designed, what you had was a Q21 day cycle, Q3 weeks. You had Taxol on days 1, 8, and 15. You had bevacizumab at 10 mg per kg every 2 weeks. Then you had Pembro every 6 weeks. So
So fun, right?
the EMR builder in me went, huh? So obviously there's can be different approaches to this. You can absolutely build this out and exactly follow protocol, but what I like about once protocols are out in the open is we can maybe tweak them, right? And what's going to be best for our patients. You know, my particular facility, when we do just plain old weekly Taxol in the setting of platinum-resistant ovarian cancer, we typically do a 28-day cycle. Days 1, 8, and 15, break, start over. It's not wrong to do it weekly with no break. It's also not wrong to do it day 1 and 8 with a break on day 15 every 3 weeks. It's also not wrong to do Bev 15 mg per kg every 21 days. So just keep in mind what's going to work best for your patient. They typically don't like to be at the infusion center. Well, they typically like to be in the infusion center as little as possible. So something to consider. And so let's also talk about sub-Q pembrolizumab.
Yeah, so a couple of things here. I think when you're giving it with IV, I don't know that a lot of us are probably going to use sub-Q pembro in combination with IV. They're already accessed, right? Like they're already geared up to go for IV therapy. One of the things that actually we discussed, which we don't have at my institution, but I found this novel, so I'm going to share it, is that both Erin and Sarah have injection-only clinics. So they don't go to the infusion center for sub-Q pembro, for instance. They go to an injection-only clinic. So it's very, if you have something like that, like completely makes sense, right? You save an infusion chair, you send them to an injection-only clinic to get this type of therapy. I think if they're combining it with orals, it makes a lot of sense to use sub-Q. And I know I've had patients who don't want to port and have horrible veins and can't get good vein access. And so sub-Q has been one I've pulled for to use for them. So different scenarios, different ways to use it. I just think you think about your combo. Are you using IV? Are you using it single agent? Are you using it with an oral? And then, especially if you have access to like an injectable-only clinic, I think that's a great use of resources and saving an infusion chair.
Yeah, I think this is a hot topic across the board. I actually saw it on the HOPA forum recently posted. What are you guys doing with the sub-Q pembro? My particular facility, we haven't started using it yet. We do plan on using it as of April 1st when we have solid, yes, billing codes in place and similar. We'll do our best. We call them shot rooms. Yeah, is to put them there. So moving on, again, our poll follow-up for you guys before we move on to our next case. Please go. There we go. So this is Carmen. She is patient diagnosed with grade 3 endometrioid adenocarcinoma. She had surgery and she had resectable disease, but she does have lung mets, so she is stage 4B. Here are her comorbidities. Here are her testing results. She is DMMR. She is also HER2 positive. The plan is to start checkpoint inhibitor plus chemotherapy. So what safety considerations do we need to address with this patient's comorbidities? Erin.
Sure. So the thing that stands out to me about her comorbidities is, of course, the COPD and asthma. And so we know that immunotherapy can cause pneumonitis. While these comorbidities are not an absolute contraindication to starting immunotherapy, they are something that I would want to monitor closely and educate the patient on. So how do the symptoms of pneumonitis look different or the same as an asthma attack or a COPD exacerbation?
All right. And as a pharmacist, what is our role in follow-up and oversight?
Yeah, I mean, I think, again, a lot of this just comes down to counseling, right? We want to recognize IRAs early. I think the other thing that I talk to patients about with carbotaxol in general that has changed with the advent of the addition of IO is that it used to be that they'd have very stereotypical symptoms at a very normal frequency, right? So you could kind of like play guesswork. You knew on cycle 2, day 3, they got diarrhea, and you could plan for that. This is very different with IO. I think the fatigue is a little bit worse, and the arthralgias and myalgias, what I see in practice, are both worse. So I do a lot of counseling and teaching on like pain management and things like that. So I think it's just setting clear expectations for patients and making sure they have a way to contact you or someone in the clinic very quickly at the advent of side effects so that you can appropriately manage those side effects. A lot of these women are still working, right? Living full lives. They have families to care for. And so making sure that you mitigate their side effects is extremely important.
Okay. So this particular patient, she was placed on her immune checkpoint inhibitor therapy. She tolerated things overall, but she starts to experience a rash. Dr. Zaholski, what would be your next steps regarding managing this adverse event?
Sure. Well, a rash could be a lot of things, right? It could be all over her body and looking like SJS, or it could be a mild rash and only, only on her chest. So I think really getting them into clinic or seeing pictures, we do a lot of that in telehealth communication with our patients. To be able to see what kind of type the rash is, it's usually maculopapular. Seeing where it's occurring, how much of their body is affected, whether it's itchy or not, so that we can provide supportive care. So really the grading of the rash and how it's presenting would impact our next steps. Referring to dermatology right away, it depends, right? So usually for, grade 2, even grade 3 rashes that look pretty typical and the time course is pretty typical with immunotherapy, we know to start those moderate to high dose steroids. If it's presenting with one of another, presentations, because immunotherapy rashes can be pretty diverse. So if it's psoriatic, if it's pemphigoid, we might need dermatology right away.
Yeah, and I'll add real quickly, I know with Taxol we can see rash too, so I think it's important too when they're on chemo, like what's the time course, when did this start, and kind of considering those types of things, whether they're still on steroids or not, as like if you do post-chemo, like post-carbo steroids, things like that, like all come into play. So there's a lot here for us to do and to help manage for the patients.
All right, thank you. So questions to ask the patient during this course of therapy and how to discuss lung health and what to watch for. So in this particular scenario, our patient with endometrial cancer, she has now had progression of her disease after 14 months of her initial therapy. The plan is, because she is HER2 3+, we would like to start TDXD. So Jen, would you like to?
Yeah, and I'll give a nod here. I don't think we really discussed this, but when you have someone who's got dual things going on in the upfront setting, right? Like how do you pick therapy? How do you select therapy for these patients? And one of the things I wanted to bring up here is that, like, for example, the endometrial 01 Destiny trial is open. And so particularly us knowing that our African American women are underrepresented in clinical trials and they can tend to have worse outcomes with endometrial cancer, probably one of the first things that I would have talked about before we talked about even chemo and IO would have been clinical trial enrollment, because there's 3 arms. All 3 of those arms for a DMMR patient are going to get IO, right? So it's whether you get TDXD with IO or you get chemo with IO. So I think that's important to consider here. I do think being DMMR, right, I don't think anyone's going to pick pursuing the HER2 pathway over IO, knowing that IO has such a strong benefit in the DMMR patient. But there is phase 2 data, right, for using something like trastuzumab in the frontline setting. So I think there's a lot to consider here and a lot to talk about here. But hopefully, if you have a trial, or even if you're a smaller cancer center, these types of people, you're at least seeing what's available for them from a clinical trial perspective. That's my clinical trial plug for the day. But yeah, I mean, I think when you're talking to these patients, TDXD, we know nausea, vomiting can be a large issue for our patients. I feel like I actually see it more than breast does. I don't know if it's because of where our tumors are and they already have some abdominal kind of symptoms to begin with. But making sure that I'm using like a 3 to 4 drug regimen for nausea, vomiting prevention. I tend to pull olanzapine a little bit faster for these patients to use, as well as watching for the neutropenia that can happen in later cycles, but then more importantly, watching for that pneumonitis. So I follow O2 levels really closely. It's like one of the first things I look at in clinic is monitoring their O2 trend throughout time, and then clear counseling on any shortness of breath changes or any cough is something that I want to know about right away, because like I alluded to with TDXD, technically at grade 2, you're supposed to permanently discontinue. So if the patient is symptomatic, that's going to be automatic grade 2, which is a permanent discontinuation as opposed to just radiographically catching it.
All right, thank you. So how do pharmacists play a role in educating patients about trial opportunities? This might depend on your site of practice. So the question is, in this particular patient situation, she's not HER2 positive. What next? What are our options? And so as far as clinical trials are concerned, we have a pretty robust clinical trials group at my institution, so I'm very lucky to work with that group. The physicians are very pro-clinical trial. Usually it's not something I have to intervene on and say, what about this? But absolutely, as a pharmacist, I'm involved in their education, in educating them about what to expect. I do let the clinical trials team talk about all the extras, like how often are you going to come for labs and this and that and that, and all those specifics. But again, making sure we set expectations. Also, as a pharmacist, sometimes I get asked to go in and talk about the difference. Okay, here's your standard of care option. Here's your clinical trial option. What's the difference? How does this change my day-to-day? What different side effects can I be looking for? So I think as a pharmacist, 100% we have a role in helping decide clinical trial enrollment, helping to determine if a patient meets those criteria, and education, education, education. So regarding AE management for other ADCs under investigation, any tips there? Like we went over.
Yeah, I mean, I think it's going to be specific. I think we're all, I know all the time I'll pull, like, from breasts, for instance, like, if I'm using sacituzumab govitecan, right? I'm like, what does breast do? Okay, I'm not going to pull atropine right away. I'm going to start with loperamide, right, for diarrhea. Again, mucositis, stomatitis prevention is key. And then monitoring, like, blood counts. Pneumonitis is kind of a class effect of ADCs in general. It may be higher with certain ones than others, but it's still something that's in the back of my mind for all patients.
All right. So that brings us almost to the very, very end. Again, QR code for you to follow up on a poll. And that is going to bring us to our very last slide. There's a lot happening here, and we've covered this quite a bit, but the take home is A, increasing diversity in clinical trials. This is absolutely something we need. Everybody needs access, not just a small subset of patients. Doing our best to work with the team to overcome barriers associated with not only treatment, but clinical trial enrollment, so that we can, again, continue to grow our data and treat our patients to the best of our ability. So this brings us to our Q&A session. And you can scan here and submit your Q&A. We have a few questions here. Some of them we have addressed. Let's go through some of these. So there's a question here about pathology. Do you coordinate a lot with pathology? For example, testing needs, results, interpretations.
Absolutely, yes. I think like a lot of institutions have a tumor board that meets weekly, and the pathologist is absolutely critical. We do in-house testing in order to kind of classify our patients by that PROMIS algorithm. And upfront testing, to reiterate, is indicated for all patients with endometrial cancer. So they are definitely getting that. Sometimes we have some difficult cases that we really need their expertise on interpreting the results too.
Yeah, agreed. I think we all help with it.
Yeah, I agree.
The pharmacist that wears all the hats. I think we are all
Correct.
those things.
Correct. I like to call it trust but verify. So I would like to start this patient on an XYZ regimen, which requires this testing and this result. I'd like to go take a little peek-see just to make sure we're all on the same page, because we're all busy and sometimes we read things wrong, or maybe we're in the wrong chart. You never know. So yes, pharmacists absolutely can play a part in this role.
And I mean, I'll put a plug in here. I just had a patient who their quantity was not sufficient on their tumor testings. Like, we don't have HER2 for that patient, and like, we just assumed because they had testing, they had done everything. But when you looked at the details of that report, HER2 is not tested, for instance. So, I mean, it does matter, right? Like, you can't just like look at the report, see what's actionable. You need to dig through it. You need to look at those details. And a lot of times we are the ones looking at those details.
A question is, what's the right way to define platinum resistance in 2026? Which I know is a hot topic.
Oh, I think that's different depending on which tumor you're looking at too. I think people argue endometrial cancer, it should be 12 months as opposed to 6 months. I also think that that hasn't been well studied or validated in endometrial cancer, but we use it anyway in clinic ubiquitously. I think particularly because we get serous subtypes that are highly aggressive for uterine cancer, so what we call UPSC, uterine papillary serous carcinomas. So we tend to use the definitions, but technically it was never validated in endometrial cancer. I mean, ovary still uses the 6-month time point for patients, but I think uterine is still a question.
Yes, no, I agree with that, right? So what we learn in school and in the books is 6 months, which we teach all the students for their exam. 6 months in ovarian cancer space determines your platinum resistance versus your platinum sensitivity. And there's also, at my institution, we might sneak in a platinum in conjunction with some other medications, even if we are suspicious of that platinum resistance. It's not necessarily wrong. We like to do a gem-cis-bev combination as well. Yeah. And then when we talk about low grade, completely different topic, but does that really matter there?
Yeah.
So.
My students and residents always ask, what if they have recurrence right at 6 months for ovarian cancer? What do we do? And I think biologically the disease behaves a lot like platinum-resistant ovarian cancer with recurrences at 6 months. So.
All right. Well, that brings us to the end. Everybody, thank you so much for joining us. There is this QR code to visit. Thank you. You can claim credit. Here is the website, and do stay tuned for any online activity based on this event. And if you won the drawing for the gift card, please see our peer review team in the very back. Oh, over there. She's over there. She's waving it up in the air. Thank you very much.